Hello, and hello to all of you, to the Equity Imperative. Myself and my wonderful colleague Pedro Delgado are going to be talking about equity this morning. And I can see from the chat already that there are quite a few people from all over the world. My name is Yvonne Coghill. I, until recently, was the Director of Workforce Race Equality in the English NHS. I was also the Deputy President of the Royal College of Nursing until recently. And having retired from the NHS after the last 43 years, my passion still is very much about health equity, about equality, about making sure that the healthcare that we are delivering across our world is accessible to everybody, regardless of their background. And so to kick off, I will hand you over to Pedro, who will start off this session.
Hi, everyone. My name is Pedro Delgado. I'm the head of Europe and Latin America for IHI, the Institute for Healthcare Improvement. And obviously, as the co-hosts of the conference, we are ever grateful for you making time to be with us right now and to have been with us for the last couple of days and for the next couple of days as well. I'm on a high right now because of the excellent session we had with Klaus this morning about building movements with passion, with love, with courage, about focusing on ourselves to make a difference, to serve others. So focusing on what's inside and believing that that's enough. What we are and what we have is enough, and that's just a beautiful message that sometimes we lose sight of in healthcare. COVID has shone a light on many issues and fast forwarded many issues at the same time. One of those things is equity. We will show you a few of the numbers, at least for the UK. But we know that in your geographies is probably similar in nature, what's happening in terms of who's suffering right now. But this challenge that we're about to pose for you and to share with you and to learn from you, actually, because we'd love to hear from you on the chat, is very much part of the world that we live in. And today we're just going to give you some data, some stories, some numbers. Then we'd love to hear from you on the chat about your experiences and any questions that you may have. And then we do want to get super practical and focus on what you can do, what we can do as a community. I'll start with IHI's triple commitment. We just refreshed this. We have a triple commitment to patients and communities. And you can see the word equitable there, to the workforce. If you heard Kater and Dawn yesterday talk about the importance of supporting our workforce on their physical and psychological health, and to society. This is an endeavor that touches every aspect of life, health and healthcare. And I put our values at the top of the slide: trust, equity, courage, and love. And I put this at the front because both Yvonne and I have lived experience in terms of our background personally, in terms of our background professionally, of grappling with equity. And similarly, no one's fully solved this riddle. No one is immune to the possibility of displaying behaviors of racism every once in a while, or any of the isms for that matter, because we are human beings and we have inherent prejudices. So we're not speaking in this session from a position of having sorted it out, but from a position we're working through it and with it, actually. And this is what we're inviting you to reflect on. We'll focus largely on three aspects of equity: health equity, healthcare equity, and workforce equity. And we will put an emphasis or an accent, if you're writing in Spanish, to the word racism and what implications that has on equity. So you've been reading the definition of health equity on the screen, but essentially is working with people to ensure that they can attain their full health potential and that no one is disadvantaged from achieving this potential. And we're talking about minority groups, different geographies. Again, race could be an issue. Socioeconomic factors could be an issue, and so on. But the crux of equity, if you see it on the illustrations, is that we ensure that everybody has a fair start, and that we're not pretending that everyone's starting from the same line when the reality is different. And we have gone as far as to say that inequities are harm. We list the 6 dimensions of quality, safety, timeliness, effectiveness, efficiency, person-centeredness, and equity. And we have learned to understand that inequities are indeed harm. When it comes to health equity, if you live in the UK and particularly in England, you probably have come across Sir Michael Marmot's work, which is wonderful. If you haven't, we would encourage you to read this document. It's been updated. The Health Foundation kindly supported the Institute of Health Equity to put together this document, which is just beautiful in the way it's written, in the way it's framed, and so on. But essentially, it highlights the gaps and opportunities that we have to close equity gaps. We also know from COVID, and if you, again, we've added the reference on the slides. If you have the opportunity to look at this, it would probably take you half an hour to read through the entire document and 5 minutes to read through the executive summary. But there's a couple of things that I picked up from the document that I thought were important. First of all, mortality rates in the most deprived areas were more than double the least deprived areas. People from Black ethnic groups were most likely to be diagnosed, and death rates from COVID-19 were highest among people of Black and Asian ethnic group. And then there's some sub-segmentation of that highlights some of the gaps around the Bangladeshi community. And lastly, because this is a global forum, I could have brought you the Latin America inequities document that the Inter-American Development Bank published in September, which is full of both challenges and opportunities in terms of closing equity gaps in the most inequitable region of the world, which is Latin America. We decided to add some North American figures here in terms of people with poor access to poor care, people from Black backgrounds being more likely to die, the incidence of diabetes on some of the populations, the homeless challenges, women with disabilities, adolescents and adults with disabilities, LGBT inequities. And we put the references at the bottom. What's important to say here is that regardless of where you're calling in from, connecting from, and regardless of the reality that you live within, it's likely that the minority groups that we have excluded for a long time in our communities for historical reasons and otherwise are not thriving. These are people who are being left behind. And in health and healthcare, it's our responsibility to be proactive about this. We'll highlight a couple of the pitfalls that we see in our conversations with health systems across the world, and also, again, provide some practical tools. But we wanted to start by showing you some data to start to create the narrative of the opportunity that we all have to work on this. And now, Yvonne shortly is going to walk you through some of the workforce numbers. Look at the numbers for quality in terms of the U.S. National Quality Strategy priorities. The Black population were no doubt disadvantaged and were receiving worse care than their white counterparts. So why is this happening? Differential access to resources and opportunity, differential application of care practices, implications that start with us as individuals, but move to every level of the settings that we work in. And then the isms. I mentioned racism before because we'll highlight that, but these isms marginalize populations. So racism, sexism, heterosexism, and so on. And what we hear often, more often than not, is a kind of external locus of control. So, oh yeah, there's loads of stuff going on outside these walls, but when people come to me or to us, I or we treat everyone the same. Then the second one, it's around, it's somewhere out there. It's complex, it's poverty, it's education, it's history, and there's little we can do in health and healthcare about that. And then there's a political question, right? Oh, so there must be a political inclination here. Why are you bringing this up? Listen, we would invite you to be a protagonist in this conversation. We would invite you to put the locus of control within, and to look at yourself in the mirror, to look at your teams in the mirrors, to look at your organizations in perspective, and really dig deep into the question, are we doing enough to close equity gaps? Our sense, again, having worked with hundreds of health systems, governments, and so on across the world, is that there's a lot to do. There's a lot to do. And we see it as an opportunity, of course, to work together as a community to close equity gaps. There is no quality without equity, and there is no equality without equity. So not just quality, but equality. So now Yvonne's going to walk you through some of the data around workforce and some of the implications of not acting really with a sense of urgency on this. Yvonne, you can click through the slides yourself from here.
Thank you so much, Pedro. And I think that what you've said really does set the scene for what I'm going to be talking about, which will be one of the isms. And one of those isms, as you all probably know, is racism, which is it's a global issue. It's an issue that we in our world have never really dealt with to make it better and to make it right. And it has a direct impact on patient care, patient safety, and patient satisfaction, which is why it's so important. And what I'm going to be talking about will be how we can understand and know exactly how this ism impacts on patient care, but also the things that we can do ultimately to make things better, because we can. And I think that's really important, that we know that we can, even though there's this great big huge issue and challenging issue, we can make things better. So to kick off with, in England, Professor Michael West and Professor Jeremy Dawson back in 2009 actually wrote something on the quality of care and staff engagement. And one of the things that was in that document, and it was inadvertent, it wasn't, I don't think, something that they were actually specifically looking for, but what they found was really very interesting. And I think it's something that we all took notice of at the time, because what they found was that the greater proportion of staff from Black and minority ethnic backgrounds that had experienced discrimination during the previous 12 months, the lower the levels of patient satisfaction. I mean, and that is actually huge, because what it was doing was making the link between patient care and staff actually feeling motivated, valued, and cared for, which is what we all want. And what they went on to say was that the experience of staff from Black, minority, ethnic groups in our NHS in England was a good barometer for the climate of respect and care for all within our organizations, which actually says then that actually we need to make sure that every member of staff feels that they are being valued, appreciated, that there are equal opportunities, that there is equity in our organizations. And what I can say quite clearly is that that has not always been the case, because we know that internationally that has not been the case. So the reasons why the English NHS decided that it was going to focus on this ism as opposed to other isms was because of this, basically. Fairness and equality in the system is one of the things that the NHS stands for. We have a public sector equality duty to make sure that things stack up for everybody across the board in the English NHS. We also know that morally it's the right thing to do to be fair and to be good and to be kind to everybody and to pay everybody, regardless of their background, respect, and to treat people with dignity. We also know, because there has been a lot of work done on this, that for every one standard deviation point of increased engagement in an organization, and we measure that through our staff survey, we save 2.4 lives. There are 2.4 fewer deaths in organizations that have higher engagement. And at the same time, we save £150,000. And that's through, people not going off sick, people not leaving, people not being stressed, all of those things add up. And there is much more in terms of money and funding in the pot for patient care. So the reason why the race equality was identified as something that we needed to work on in the NHS wasn't just about it being a fair and the right thing to do and making sure that people had equal opportunities. There was a hard-nosed business case for doing this, because what we know is that people of colour actually have a much worse experience than their white counterparts. And we know that there are things called microaggressions, which impact on the lives of people of colour. And some of you will have heard of the work of Arline Geronimous on biological weathering, and some of you might not have. But this was really another thing that I found incredibly fascinating on my journey to understanding and knowing about race. And what we know is that age doesn't only capture the length of time you've been alive, it captures the experiences that you have in that time. And if those experiences are not good experiences, it impacts on you physiologically, not only psychologically, but it impacts on your physiological health, which means that if you are from a Black, Asian or minority ethnic background, and your life experiences are much worse than your white counterparts. And of course, in the work that Michael Marmot has just done earlier this year in our country, it shows that the gaps in people's experience are getting wider, and a lot of those people actually come from ethnic backgrounds. It means that it will impact on you physiologically. Now, we haven't got all the time in the world here to speak about how that would impact on people in terms of COVID, but it makes a lot of sense if you are somebody from one of those backgrounds and you have been experiencing what we call microaggressions, microstressors throughout the length of the time you have been alive, and it has impacted on your physiology, and you are less likely, you are more likely, I beg your pardon, to pick up illnesses and diseases and so on, because your body is more compromised than others. Then it doesn't take a genius to work out why it is that we have disproportionate numbers of people from Black, Asian and minority ethnic backgrounds becoming susceptible to COVID and so on. And these microaggressions are things that are very simple things, but if you're living your life constantly where you are othered by society, where you feel that you aren't getting the same services as others in society, where you are less likely to have a better education, where you are less likely to be promoted, where you're more likely to lose your job, and that's the constant of your everyday experience, what happens is that will be infused into your body, into your psyche, into who you are as an individual, and your responses to society will be sometimes defensive, sometimes disillusioned, sometimes unhappy. And for me as a Black woman, there's this thing about, Black women being full of rage and anger. Well, is it any surprise that there is anger and rage when you see others in society actually going up the ladder much quicker than you, actually getting more than you, their children actually progressing more than your children, simply because of the additional melanin in your skin? You are not getting the same treatment from society that others get. So I think it's really important that people understand that, and the link between that, not being cared for, and caring and patient care because it's a very, very, very strong connection. And in our NHS, it's really particularly important. And it's particularly important because we have 1.4 million people working in our NHS, and 20% of them are people of colour, people from different backgrounds. And that means that quite a substantial number of people, doctors, nurses, managers across the board, allied health professionals, come from groups other than white British. And so we know that in order for our patients to get better care, we have to start treating our staff equitably and well. But unfortunately, you can see on the other side of this slide, where we have all the numbers in terms of the people of colour that can or are at the moment in higher level positions, you can actually see very clearly that there is something going on in our system that is stopping and blocking people from moving up the ladder. And of course, it is the equity thing again, and what is going on in our society. And that is why when the chief executive of the NHS now, Simon Stevens, came into post, he decided that he was going to do something about this ism, because not only is it the right thing to do, but actually we needed to address it in order to make sure that the staff that we have in our service were actually going to deliver high quality patient care for all of our patients. Very, very important. I'm not going to go into this in depth and detail because we just don't have the time. But what we have done in the NHS is to come up with an initiative called the Workforce Race Equality Standard. And what that does is it measures the experience between our white staff and all of our staff of colour. And it's shown us over the last 5 years the difference in experience that those groups of staff have. And I have to say that every single organisation in the country is involved in this. So we have very robust data showing us the thing that we already know. But actually, when it's written down and it's data and it's 5 years worth of data, people actually start to sit up and pay attention to it. And what we know is that if you are from a non-white background, you have a much worse experience in our NHS than if you are from a white background. Now, remember what I said earlier about that linking to patient care and the importance of that. So what we're trying to do is to close the gap on that experience to make sure that everybody has the same experiences, positive experiences within our service. And these slides, the next slides I'm going to show you, will just give you an outline and a taster of the work that we are doing and how we're trying year on year to actually improve the experiences using those indicators. And you can see from the indicators 2, 3, and 4 on here that we are moving in the right direction, but very, very, very slowly. Those are the indicators we call process indicators, and those process indicators are things that you can do something about almost immediately. So you can change the way you recruit people into post, and you can overnight change the numbers of people of colour that you have in your organisation at all levels. You can change the processes that you have for formal disciplinary processes. The trickier bit is to actually change how it feels to be around here, the culture within an organisation. So our indicators 5, 6, 7, and 8 are about how it feels to be around here. And as you can see from some of the data on here, you can see that people who are from white backgrounds have a better experience, a better feel of being in the organisation than people from other backgrounds. And just very quickly to quick through, you'll see this is just a slide showing the percentages believing that the trust provides equal opportunities. You will see again the differences in experience between Black, Asian and minority ethnic staff and white staff. Similarly, this is about, have you personally experienced discrimination at work in the last 12 months? Again, you can see what's going on in our service. And this is 2019 data. This isn't 1818 data or 1819. This is up-to-date stuff. And the other thing that needs to be remembered, and we're doing work on this, and it's really very, very important, is this, that not all people of colour have the same treatment, and that there is in our NHS a hierarchy of preference. And that hierarchy of preference, you can see very, very clearly on this slide, shows you, depending on the amount of melanin in your skin and where you come from, whether or not you feel that you're having equal opportunities in your organisation. And for every single indicator, when you break it down into these ethnic groups, what we find is that if you are from Africa, and particularly if you are from Nigeria, your experience of working in the NHS is much worse. And that matters because we have a substantial number of people from Africa working in clinical services within our NHS. So doctors, nurses, and so on. So there's something that needs to happen, not only in terms of a global perspective, because we bandy these terms about, don't we, ethnic minorities and Black people and Black and Asian and minority ethnic groups. But actually within that, there are different groups that get very, very, very different treatment based on the amount of melanin in their skin, based on their faith, based on where they come from in the country. And we have to start breaking that down in order to make sure that everybody gets equal treatment so that our patients ultimately get better treatment. So, Pedro, are we going to be having a conversation now with our participants?
Yeah, Yvonne, thank you. And thank you for sharing the detail of this work on workforce, which is again, a huge issue that starts not just when people become part of the workforce, but in the way that we provide or not access to education to people as they develop and so on. I wonder if we could just pause here for 30 seconds and see on the chat if people have any reactions or questions, or if any of this resonates with your realities locally. We have talked about health gaps and showed you the Marmot review number, talked about healthcare gaps and showed you some of the challenges with COVID and some of the data both from the UK and the US, and we have talked about the workforce equality. So we have covered a very wide range of issues. Are there any questions or comments that people are willing to add on the chat before we move on to describing some practical tools to address concretely? So we're going to pause here and be silent for about 30 seconds to see if there's any comments or questions on the chat. Libby, as comments start coming through, we'll try to reflect on each of them. But it's a fundamental question, right? Can we see them changing? So I'll give you my assessment. Obviously, it's an N of one. I happen to work in both Latin America and Europe with hundreds of health organizations, and my reflections are essentially based on that. So the answer to that is yes, right? The fact that we're having this conversation, that this is a topic at the international forum, that Dawn and Kater mentioned equity as one of the one of 6 key issues to kind of carve a new path towards a better future. The fact that organizations are starting at least to articulate equity as an organizational priority and action strategies that are connected to that, I think are signs of definitely, can we see things changing? Yes. Are we at the point of needing to move from understanding the data to having strategies to close the equity gap? That's why we titled this session an imperative. We think it's imperative. We almost see it as an ethical responsibility that we have with each other as an improvement community to move from just saying that this is something important, and perhaps at times putting it out there as something that is important, but it's not necessarily our responsibility, to starting with ourselves as individuals and then moving on to work with our teams and with our organizations. We at the Institute for Healthcare Improvement have been for the last 5 years tackling inequity in very concrete ways with our internal staff, in terms of the diversity that we have or not, in terms of the experience that people have in the workplace and so on. So I personally think that things are moving. I think we have a long way to go. Any comments on Libby's question?
Yeah, I absolutely agree with that in terms of things changing. Things are, from my perspective, very different to how they were when I was growing up in this country, in England. But things are moving incredibly slowly. It's not a surprise. It's taken 400 years for us to get to where we are with this, this particular agenda. So it's not going to be 2 minutes before we change everything again. This is, deeply ingrained, embedded stuff. The systems that we have are perfectly designed to give us what we've got, and that means more people understanding that there is an issue here, and more people empathizing, because empathy is really important with some of this, and wanting to make the changes. And of course, the more people we have who understand and who want to make changes, the more likely we are to see things change. And so it's happening, but incredibly slowly at the moment. And my wish and my hope is that we get a little bit more impetus into this, little bit more, drive and energy to really, really push against the inequities that we have in our world, so that people are, regardless of where they come from, feel that things are moving and things will be getting better for them going forward. So yeah.
And Yvonne, just to reflect on Susanna and Pernil, I'm hoping that I'm pronouncing your name correctly. I may not be, but Susanna highlights challenges with a specific segment of the population, Arab people, and Pernil talks about homeless and refugees and so on in the Danish context, and it's a sign of what we're seeing, right? The minority groups vary, obviously, depending on the country and the geography and so on, but the symptom of inequities is present. Definitely, these are people that are being left behind, who are not thriving, who actually we need to be more proactive around, for sure. It's not going to happen otherwise. Hugh, is this time that we're in an opportunity to speed up? Is it ever, Hugh? I mean, I honestly think COVID has brought on a huge amount of challenges to the way that we even live, right? Depending on who you are, you may be on lockdown right now. What an opportunity, what a platform. Data that's coming through so many geographies is saying to us, listen.
I think so. I agree. I think that's absolutely right. And I think at this time, with the George Floyd thing that's gone across the whole of the world, and with COVID and so on, this is a really good time for us. There's a window of opportunity, and with windows of opportunity, they usually close, don't they, after a while? But I think we have a window of opportunity now to actually do things differently, make a real step change and make a difference. I mean, we've seen across the world, it's not just people of color that are rising up and saying we need fairness and equity, it's everybody. And so that's really important, that we have, a majority of people, not just a minority, saying we want change. So yeah, is the answer to that, for sure.
So why don't we move on with some of the content, because we do want to get into some strategies with some tools. Listen, every framework is imperfect, some are useful, and we're hoping to leave you with some useful ones here. Hannah, if you can hear us, I can see that one of my slides coming up is only showing part of the content because it was meant to be animated. If the system doesn't animate, and if you could help us take the white boxes of the slide, that would be super helpful. So I'm going to focus largely on the Achieving Health Equity white paper because it's a guide that supports healthcare organizations that are trying to take concrete steps to move to a better, more proactive place. But I'll also invite you, of course, to look at the materials on our website around pathways to population health. And obviously, within the UK context, there are right now a group of organizations that are committing to becoming anchor institutions, healthcare providers who are committed to maximizing the power that they inherently have because of the number of people they employed, because of their status in the community and so on, to go beyond just providing healthcare. So both in the way that we provide healthcare and how we use data to understand inequities, in the way that we relate to our communities, the Anchors framework is an absolutely fantastic one. So these are 3 invitations for materials to look at. And then On this slide, if I was to get into the framework for healthcare organizations to improve equity, I have that there are 5 planks to this. And again, Hannah, I'm not sure if I click here, yeah, nothing's going to happen. So if there's a way of showing this completely, but I'll walk you through it. The first one is to make health equity a strategic priority. And that sounds pretty straightforward. You'll be probably not surprised, actually, at the fact that it's not necessarily a strategic priority. There's finances, there's waiting times, there's safety. Equity is not necessarily articulated as such. By doing so, you can perhaps secure some sustainable funding for equity initiatives. You can integrate it into strategic plans, and obviously by making it a priority, you start to see it everywhere in written documents of the organization, in of local leaders and organization-wide leaders, and so on. So that's the initial plan of the equity framework. I'll walk you through the others verbally, and perhaps you can access the document on your own time. The second one is to ensure that you can develop structure and processes to support health equity work. And that is human resources, financial resources, and data, at least. So develop structure and processes to support health equity work. The third one is to deploy specific strategies to address the multiple determinants of health, where healthcare organizations can have a direct impact. So it's not everything, but the ones that healthcare organizations can have direct impact. The fourth one is to eliminate institutional racism within the organization. And there are specific strategies to do that. And the last one, obviously, is to develop partnerships with community organizations. Again, the white paper has a number of very specific recommendations within each of these categories. And what I'll do is I'll try to type them into the chat once I finish speaking and pass the ball on to Yvonne.
Okay, thank you, Pedro.
Yvonne, give me 1 second to allow you to go onto the 7. Oh, there it is. So now, hopefully,
you've got it.
You can see the framework. So I'll just give you a few seconds to either take a screenshot or read through it. But this is essentially what I just walked you through. That's fantastic. Thank you. That's brilliant. So we try to make it very pragmatic, very usable, very applicable. So if you are part of an organization, and some of the questions that were coming through before were about, I'm convinced, but my team aren't. If we can ensure that we can have both a ground up and a top down approach to this, it would be brilliant to ensure that if you're committed to it, your organization can come right behind you. Hannah, can we control the slides from here onwards?
Yeah. Unfortunately not.
Okay, great. So if you can click through them, that's fine. So if you can click once again. So listen, just because it starts with the individual, and if you can click again, you do have a responsibility, and click a couple more times, Hannah, perhaps. We have a responsibility to raise the profile, to discuss the root causes, and create an environment to do that. It requires courage, and if we have the ability to, we can also set strategy and align resources. But leadership of health equity is not just talking about the commitment to health equity. It requires some very concrete actions. And Hannah, once more, if you can click once more. And then my last slide here is to start with ourselves. If we could, this test takes a few minutes. Start by exploring our own biases, by advancing conversations within your organizations, then by educating team members and becoming part of that education process ourselves, by reviewing our policies, practices, and data collection, by ensuring that we do look at stratified data. Looking at a whole set of outcome data is important so that we can tackle gaps. But within that set of outcome data, looking at some of the perhaps racial distribution of how those outcomes are achieved, almost always highlight opportunities. And then obviously to use improvement methods to start moving from where you are to where you want to be. So Hannah, if you can click from here on in, it's all Yvonne. We'll be keeping an eye on the chat box for sure. Yvonne, go for it.
Am I able to? Yeah. Oh, here we go. So, you know, the thing about the work that I've been doing on race and workforce is incredibly important. And as Pedro has outlined, there are strategies in which we can use to make a difference. And I've recently finished a piece of work in which I'm incredibly proud, and I haven't got the link here, but I will make sure that you guys get the link, which is about improving race equality in London. London, we have 50%, 50%, people of white backgrounds, 50% of people from everywhere else in the world. This statement, this vision, was pulled together by the nurses, doctors, managers across London. They came up with this statement, and I think it's absolutely brilliant because it is about what all of us want in our workplace. That the decision makers who look like me, there should be more decision makers who look like me, because in our NHS there are not. I've shown you the data on that, who make choices that don't disadvantage me in my future. The leaders who don't look like me would be understanding, authentic, and committed to inclusion through their actions and how they speak. And it's the thing that Pedro said about, it's not just about saying that, paying lip service to the fact that we want equity. It's actually doing something, visibly committing to this agenda. And that my difference would be valued. It would be a buzzing place to work, and everyone would feel uplifted and part of a shared vision to deliver high quality patient care. And I cannot, for the life of me, imagine that not everybody who works in healthcare wouldn't want that. I should imagine that everybody wants this, because it really is, I think, one of the best visions that I've seen on this agenda. So next slide, please. And so when people were asking me, and lots of people do ask me, well, Yvonne, what do you do about this? What do you do about this? I came up with this, which is how to be an authentic ally. And actually, it isn't just about being an authentic ally for race. You can use this model to be an authentic ally for all of the isms, all of the protected characteristics. And, as Pedro said earlier, the first thing that it has to start with is you as an individual. And the first day on here is appetite. You have to ask yourself, do I have the appetite to be an authentic ally? Am I going to spend time, energy, commitment? Am I going to be courageous enough to actually work on this agenda? And you have to do that work on yourself. You have to ask yourself those questions, because invariably we don't. And we just launch into it, and actually we feel fed up and tired and, all those things, and we just step out, which is actually worse, I think, than not stepping in at all. So once you've asked yourself the question and you actually have the answer to that, and if the answer hopefully is yes, you have to then start asking the questions. You have to read, you have to talk to people, you have to watch videos and webinars and be involved in things to learn, because this isn't an agenda that you will understand by osmosis. You have to do the work around it to understand and know exactly what it is that you need to know. And once you've done that, the internal thing that needs to happen is you accepting that there is a problem. Because a lot of people don't. They come up with lots of excuses as well. It's not really like that, is it, Yvonne? Or it's, maybe it's just your imagination. Well, actually, the evidence and the data shows that it is not. And then you come to that open acknowledgement, the acknowledgement that there is an issue and a problem, and it is complex. And that acknowledgement has to be external to yourself, whereas the acceptance is internal. So you are actually saying to people, I know that there is a problem and we need to do something about it. The apology is about acknowledging and knowing that there is something happening for some people, and you're sorry about it. It's as simple as that. People said to me, well, Yvonne, maybe it needs to be empathized. I said, no, this is about really feeling sorry that people are having to go through something that potentially you're not going through. And then don't assume that you know the answer. There's a lot of assumptions around this agenda where people say, well, maybe we ought to do some unconscious bias training, or maybe we ought to do some mentoring, or maybe we ought to do some of this or that. Don't assume that you know the answer. Ask people. Seek to understand what their lived experience is before you actually start making plans. And only then do you need to take the demonstrable action to make a difference. And this model has been taken up by people in the service, in the NHS, and they're using it for training and development of allies, which I think is a really good thing. But it kind of works because it gives people something to hook onto, and an opportunity to really think about this agenda. And I think that's one of the key things for me and why I actually developed it. Can I have the next slide, please? I think that Pedro's already described, what needs to be done and how you need to go about it and how you build a strategy. This model was developed by Dr. David Williams from Harvard University. And what he said to me when he actually gave me the model was that leadership is absolutely the key. You need to have leaders who are going to be able to feel that they can talk about the agenda, feel comfortable around the agenda, and actually do have demonstrable actions around it. So it's really important that we have that. The accountability. So who's going to be accountable for making sure that equity stacks up? And that needs to be your senior leaders as well as everybody else. So there needs to be accountability around all of this. And that accountability comes through making sure that you hit your targets, you change things. We have something in the NHS called the Model Employer, which unfortunately I didn't put up here, and I should have done. But we can share that with you. The Model Employer looks at all bandings, all grades of people across our NHS, and it gives every organisation a target to hit in terms of equity for all bandings in every single organisation. So there is no excuse. So if your organisation has 30% of its staff from non-white backgrounds, then at every single level in that organisation, there should be 30% of staff from a non-white background sitting at those grades all the way up the organisation. And every single organisation in England has got their own document with those targets in it, and it's a 10-year programme, which we're 2 years into now. And of course, already people are beginning to fall behind, but that's another story. So targets. Communication is really key, and the communication has to be making sure that people understand why we're doing this. A lot of the time people don't understand, or they think it's, it's just because we're going to be nice to those people of colour. This is about patient care, patient safety, patient satisfaction, and making sure that everybody, understands why this is important, and drip feeding that into the organisation, a steady drumbeat of communication, as Dr. Williams always calls it. Having the right resources for it, and of course, celebrating our successes, really important things, as well as working on the operational interventions that I talked about, the things that you can just change very quickly overnight. And also looking at your culture and changing the culture in your organisation to be much more compassionate and more of a learning culture than the cultures that we have, which are all about delivery at the moment. It is about working with people to get the very, very best out of them. So, we do have approaches. Pedro's shown a few, I've shown a few, that can actually make a difference around the agendas to make equity something that is, a living, breathing thing in all of our organisations. Next slide, please. And I think for me, finally, it's to say this, because, with the Black Lives Matter agenda, what we've been hearing a lot is that, all lives matter. And of course they do. Everybody's life matters. But I think on this slide, there's something missing. And I think that the bit that's missing is that, you have everybody else's hands up, and you have black hands down here, because that's the reality of it. This slide actually shows that what we don't want is to make things better, much better, for Black and ethnic minority people while everybody sits here. The plan is that everybody, regardless of their background, has the same opportunities, and that we all are at the same level. So I think it's really, really a good slide. But actually, if I was going to do this slide myself, I would actually have another set of hands showing exactly what I've just described. And that's what we're aiming for with equity. It's about making sure things are fair and appropriate for everybody, so that we get in healthcare high quality patient care, patient safety, and patient satisfaction. So thank you. I think that's the last slide.
That's awesome. And if you can put the next slide, we would love to hear from people even beyond this session. And honestly, this is what we miss, being with you in person, right? And walking around the room and giving you the microphone and inviting you to come in verbally. So we'll use the chat. That's what we have, and that's what we'll use. Let's just maximize the opportunity to interact through that. A question from Paulo. Paulo, I think, because I think I saw you in the session earlier, you might be dialing in from Portugal, so thank you for being with us. Yvonne, do you want to react to Paulo's question?
I can't see the question. Where is it?
It should be on the chat box, but I'll read it to you anyway. Okay. You have it. Some organizations are very explicit about being equal opportunity employers. Do you think this works?
About being equal opportunities employers? Well, you see, equality and equity are two different things. And I think that, probably about 10 years ago, everybody was saying, we're all about equality. Equality is what we're about, and we are equal opportunity employers. Being an equal opportunity employer doesn't necessarily give you equity, because if you do the same things as Pedro's slides showed at the very beginning, the pictures, if you do the same things for everybody, and those people are coming from different places, then you're not going to get the same outcome. It's a simple thing for us to think about and to know. But I think back in the day, people were very much about, if we do everything for everybody the same way, then we get equality. Actually, we don't. So in order to get equality, you have to do things differently for different groups of people. And I think that people are beginning now to understand that, just having a blanket across the board initiative for everybody isn't going to give you what you're looking for. So, it's definitely not enough. You need to do things a bit differently in order to get a different outcome.
That's a lovely distinction, Yvonne. I think I shared with you the piece I wrote on Medium around that very.
It was really good. It was excellent. You should put it out.
And how important it is to actually not confuse them, because the concepts and the words sound so similar, but without equity, we can never achieve equality, right? So if we tackle equality without tackling equity, we may be increasing the equality gaps. Chrissy Nelft, maybe Laura O'Neill's still there, and if so, please send her our regards. Congratulations on your new post, and delighted to hear that you're getting some useful tools here to use back in your organization.
Can I just jump in there?
Sure.
Chrissy, Pedro. I did a piece of work, or QI piece of work, with some of the IHI fellows in Sheffield, probably about, 3 years ago. And we have a really nice document about the using QI to move the agenda dial on race equality in Sheffield University Hospitals Trust. And I'm more than happy to share that with you. I am a friend of Nelft. I know the Nelft people very, very, very well, and I'm more than happy to share and help share that with you, so that you can actually take that forward. No problem at all. Sorry, I interrupted you, Pedro. Sorry.
No, I'm glad you said that. The more practical, the better. As you probably have seen as a participant, this is a forum that aims to share lessons with humility, but also share tools so that you can add them to your portfolio of the many things that you use every single day. And Yvonne, I just shared the link to the Medium piece about equity and equality. So thanks for the.
Well done. It's great.
I completely forgot to put it in.
It's a great read. And I think that's the point, isn't it? There's lots and lots of tools and things to read and so on and so forth. But, obviously we couldn't put them all here. But of course, they're coming back to both of us. We're thinking about all the things that we could actually have shared with you, but just not enough time to do so.
Absolutely. So we have about 3 minutes, and we're just gonna stay quiet for 30 seconds, see if there's any other comments or questions. What a privilege to be spending a little bit of time with you. Again, we'll send you a virtual hug from wherever you are and from wherever we are. And we hope that you will stay safe, will stay well, and will continue to make a difference. If you were there this morning, you probably heard the hummingbird story. Please, you have the power to make a difference with the resources that are implied in you being you. So that uniqueness is already something very special. So thank you for spending the time, investing a little bit of time on learning with us around equity. Hopefully some of those tools will be of use to you. And again, we'll be silent for about 30 seconds, and then I'll give Yvonne the last word to close the session.
Thank you.
Okay, Yvonne, why don't you go for it?
Okay, well, it's from my perspective, it's just to say to every single person who's been on this session, thank you very much for coming, and I hope that some of the things that we have said have struck a note, struck a chord, and that people are actually going to go away and think about what they can practically do to help make things better in terms of equity in their organizations. Going to start thinking about how much they are willing to put of themselves into this space to make sure that there is equity and that everybody has equal opportunities to be the best that they can be, so that ultimately our patients get a better service from all of us. So I think that's probably all from me, Pedro. So thank you.